Assalamualaikum warahmatullahi wabarakatuh. Today, I am Nabilah Natasha Binti Baktiar presenting my clinical case study on one patient from my posterior ocular pathology class. So the patient whose name is Mrs. H is a 49 years old Malay female. This patient has been attending the IIUM medical eye specialist 4 times. She has a past medical history of diabetes mellitus and she has been experiencing an undilated right foot injection. What is that? It is a steroid injection or cortisone shot that reduces the swelling, stiffness, and pain in her body, her foot and ankle. The steroid acts like the natural hormones that her body to stop the inflammation. So when she presents at the IIUM Medical Specialist Center, she has achieved complaint of blurry vision in both eyes, but the right eye is more blurry compared to the left eye. Next, the medication that she takes was Actrapid 14 vial, amlodipine, perindoprine, and Lasix. Actrapid is used to reduce the high blood sugar level in patients with diabetes mellitus, and perindoprine is used for treating high blood pressure, which are hypertension and heart failure. Next, amlodipine used either alone or in combination with other medication to treat the high blood pressure. And last but not least, the Lasix that used for treating the swelling of the ankles, feet, legs, or even the brain or lungs. So this medication may indicate that the patient have diabetes mellitus or hypertension. The objective finding shows that her VA was 624 for the right eye and the left eye was 460. That shows why she complained blurry vision. And when given the pinhole, the right eye shows no improvement while the left eye shows little improvement to 560. The IOP for both eyes was normal. For the anterior assessment, for the first visit, the color conjunctiva for the both eyes show no abnormalities, which is a white color, and the cornea showed no opacity, and the anterior chamber was also normal. But when it comes to the lens, there was nuclear sclerosis. So what is nuclear sclerosis? Nuclear sclerosis is a condition in which the nucleus or the central part of the lens of the eye hardens or gets cloudy. Nuclear sclerosis is common in older adults as part of the aging process of the eye. However, it can lead to severe complications like nuclear sclerotic cataracts, in which the clouding of the lens causes significant blurring and vision loss. Nuclear sclerosis is caused by the proteins in the eye lens that naturally break down over time. They clump together and cause hardening that impedes light from passing through the center of the lens to the retina. And next, the important assessment that I will investigate further regarding this case study is the posterior assessment. For both eyes, the macular area showed the cystoid macular edema. On both eyes have cystinoid, rupture, diffuse exudate, and have blood hemorrhage. More than 20 intraretinal four quadrant. On both eyes, what the diagnosis for the first visit was this patient have diabetic macular edema, cystoid macular edema with early cataract on both eyes. The plan that ophthalmologist suggested was to perform intravitreal eccentric injection for 3 doses that followed by focal or grid laser that reduced full PF80 5 times per day on both eyes. The next visit after first injection, the VA improved for both eyes, and the pinhole also have improvement, and IOP still normal for both eyes. But the difference in the second visit was that this patient came with a new diagnosis, which are subconjunctival hemorrhage on the left eye, and the right eye was still white color, and the other result was still in the same with the first visit. So subconjunctival hemorrhage occurs when a tiny blood vessel breaks just underneath the conjunctiva because it can't absorb blood very quickly, so the blood gets trapped. So the common cause was related with the systemic vascular disease such as diabetes and hypertension, and the patient have this disease. And the other that cause might cite the effects of the eccentric solution from the injection. The first intravitreal injection was the day before this second visit, and the doctor performed the intravitreal eccentric injection on both eyes because the diagnosis was she have diabetic macular edema. So the ophthalmologist plan was to give her an intravitreal gut-Vigamox injection. The injection size that ophthalmologist chose was inferior temporal. Eccentric injection is anti-VEGF injection, and eccentric is a recombinant humanized immunoglobulin antibody fragment developed for intraocular use. Macular edema is a swelling or collection of fluid in the central part of the retina. The fluid collection occurs due to main reason: vascular component and inflammatory component. Vascular component due to release of VEGF by the diseased retina. This effect of VEGF is counteracted by anti-VEGF drug like eccentrics. Inflammatory components, the diseased retina also release these different inflammatory mediators, which contribute to the swelling. This inflammatory component is treated by giving intravitreal steroids. As mentioned earlier, this is where Ozurdex is used. Ranibizumab binds to the receptor binding site on VEGF-A, which inhibits the binding of VEGF molecule to the receptor on the surface of endothelial cells and blocks all isoforms of VEGF-A. It basically prevents the VEGF molecule from having its desired effect. This is how eccentric reduces the macular edema. For the third visit, the VA for the right eye drop and the left eye still remains the same, and the other results showed no difference compared to the previous visit. But during this visit, the posterior assessment shows that the clinically significant macular edema with succinate ring on the occiput. Clinically significant macular edema (CSME) is defined as one or more of the following, which are retinal thickening at or within 500 micrometer of the center of the macula, hard exudate at or within 500 micrometer of the center of the macula. And the fourth visit, the VA improved a bit rather than the previous visit, and the others the same. The new finding on the fourth visit was the anterior assessment, which the lens showed the thick posterior subcapsular cataract and the grading nuclear sclerosis for the left eye more severe compared to the previous visit. Thick posterior subcapsular cataract is opacification in the posterior or back portion of the crystalline lens, and it is caused by it appears at the back of the lens capsule, and the capsule becomes thickened. Thickens means less transparent. The diagnosis in this patient was diabetic macular edema on both eyes. So I want to explain a bit about what the disease is, and I will relate it with the findings. So what is it? DME is accumulation of excess fluid in the extracellular space within the retina in the macular area, typically in the inner nuclear, outer platform, Henle's fiber layer, and subretinal space. Classification: what ophthalmologist diagnosed she was DME, because when we look at the fundus photograph, figure 1, it can classify as severe non-proliferative diabetic retinopathy, NPDR, because when refer to International Clinic Diabetic Retinopathy and Diabetic Macular Edema Disease Severity Scale, figure 2, the fundus showed that blood hemorrhage more than 20 intraretinal for quadrant. And the other diagnosis was the patient has severe maculopathy because retinal thickening or hard exudates involving the fovea. This figure 1 also showed the exudate will form a ring or succinate pattern around the leaking vessel, which may be seen as a cluster of microaneurysms. These were findings that were found during the third and the fourth visit. Hard exudate were also present in this figure are distinct yellow-white intraretinal deposits, which can vary from small spurts into larger patches, and which may evolve into rings known as succinatus. Ultimately, large confluent plaques can form. Since we already learned about the diabetic macular edema during posterior ocular pathology class, I wish to elaborate more about the pathophysiology of the diabetic macular edema and share my understanding or knowledge that I have gained throughout my posting and lectures. Figure 3 is a schematic diagram of diabetic macular edema. It explains that microaneurysms or damaged capillary resulting from the breakdown of the blood retinal barrier leak fluid to the extracellular space, resulting in a swollen retina. High blood sugar, also known as hyperglycemia, that affects people with diabetes. The chronic hyperglycemia-related accumulation of advanced glycated end products (AGEs) disrupt the blood retinal barrier characterized by endothelial cell junction breakdown and parasite loss. The inner BRB is composed of endothelial cells in the retinal capillaries, while the outer BRB is composed of retinal pigment epithelium cells. Altered BRB leads to interstitial fluid accumulation within and underneath of the retina through leakage of molecule depending on the intact cells to cell junction. Resorption of DME is dependent on the adjacent capillaries and retinal pigment epithelium. Resorption of fluid may leave behind lipoprotein residues seen as exudates. The diagnosis that we can look at the figure 4 that has 3 pictures for first visit, second visit and third visit. In first visit left picture, retinal nerve fiber layer OCT showed borderline thinning in the superior and inferior, but nasal showed more thinning, which seemed to improve during the second and third visit for superior and nasal. However, the inferior still shows borderline thinning. Optical coherence tomography (OCT) provides for retinal nerve fiber layer (RNFL) thickness measurements and has become an essential clinical measure for objective glaucoma assessment. But in this patient, mostly normal for both eye in third visit, and indicates that the patient has no glaucoma because glaucomatous optic neuropathy is characterized by thinning of the peripapillary retinal nerve fiber layer (RNFL). For the second diagnosis is cystoid macular edema. What is it? CME is the accumulation of fluid in the outer plexiform and inner nuclear layers of the retina, with the formation of fluid-filled cyst-like changes. Based on the B-scan in my findings, this shows that have microcystic spaces into large cavity and have subsequent lamellar hole formation at the fovea, and loss of the foveal depression, thickening of the retina, and multiple cystoid areas in the sensory retina. The cystic spaces are round and originate around the outer plexiform layer, but can progress to involve the photoreceptor and the inner retinal layers. The symptoms that when the patient first visit showed that the patient having CME, cystoid macular edema, which are blurred vision and vision that decrease over and over time. This is because of the patient having diabetes mellitus. So I have provided 2 slides. The second slide is a summary and additional information of this case study. That's all from me, and thank you everyone for lending your ears and attention. Thank you so much. Assalamualaikum.